Mike Gibson, I'm here with my good friend and colleague, Deepak Bhatt. Deepak, a lot of hypertension out there, and you've dealt a lot with resistant hypertension. Talk to us about the role of hypercortisolism in resistant hypertension and the results of the momentum study you're looking at.
Well, that's a great entry point here for this topic. There is a lot of hypertension out there. It's growing worldwide in prevalence. A component of that is resistant hypertension. You can argue on the exact percentage. Some would say, around 10 to 15% of patients with hypertension have resistant hypertension. By that, I mean on at least three medicines of different classes at maximally tolerated doses. One's a diuretic and still have blood pressure that is above 130/80, or on four different classes with blood pressure at any level. So that's a quick and dirty definition of resistant hypertension. Now, a component of that resistant hypertension is due to endocrine causes, and hyperaldosteronism has gotten a lot of attention lately as a cause of resistant hypertension. But what hasn't gotten quite as much attention is hypercortisolism as a cause potentially of resistant hypertension, of secondary hypertension. And that's what the momentum study was designed to address.
How much of it is out there? How much hypercortisolism out there?
Well, that's really the bottom line and primary results of the momentum study. And maybe I'll just say a word about momentum study. We took a little over 1,000 patients where they completed a dexamethasone suppression test, or DST. And in those, just a quick refresher actually, to do a dexamethasone suppression test, basically a patient takes 1 milligram of dexamethasone around 11 p.m. tonight, and then tomorrow morning around 8 a.m., they have a blood draw for cortisol, a blood draw for dexamethasone. And if the post-dexamethasone suppression test cortisol is greater than 1.8 micrograms per deciliter, and the dexamethasone is greater than or equal to 140 nanograms per deciliter, then we consider them in the study and even clinically to have hypercortisolism. And we enrolled a little over 1,000 patients, 1,086 patients who completed a dexamethasone suppression test. So pretty large sample, the largest US-based sample ever done to address this question. And what we found, the punchline, the primary endpoint, was a prevalence of hypercortisolism of 27.3%. So
Whoa, it's a
296,
lot
yeah,
higher than I would have thought.
not what we learned in medical school. So
No.
yeah, so out of the 1,086, 297, 27.3% had hypercortisolism. So that's a pretty high number. In medical school, when I was taught about hypercortisolism, what I was told was look for, a buffalo hump, no
Right,
faces. But,
right.
here, that's not what we're talking about. We're talking about people, that look to the physical exam, to the physician's eye, to be quote unquote normal. But in fact, what is lurking there unseen is this very high prevalence of hypercortisolism. As well, I'll mention this wasn't necessarily the primary goal of this study. The primary goal was to look at hypercortisolism, but we snuck a peek as well at hyperaldosteronism, which was also present in about 20% of the 1,000 patients, and specifically in those with hypercortisolism, it was 21.5%, so 64 out of the 297 patients. So in other words, it turns out of this overall 1,086 patients, 5.9%, you could say 6%, had markers of both hypercortisolism and hyperaldosteronism. So I don't know that either of these are totally on a cardiologist's radar, but certainly the hypercortisolism had not been on my radar prior to seeing these data. I suspect the same for you and the vast
No.
majority of cardiologists.
But it's even higher, correct me if I'm wrong, it's even higher than hyperaldosteronism
It is in this population
in
for
this
sure.
population. Wow.
Yeah. So, truthfully, I would suggest, and it was kind of the punchline of this late breaking presentation, that in patients that have true resistant hypertension, we use the AHA definition, but, that have, I guess I'd say, a common clinical definition of resistant hypertension, we ought to be screening for hypercortisolism and for hyperaldosteronism.
Yeah. Wow. Deepak, I'm amazed. I mean, this has big implications for testing and then obviously subsequently for treatment.
I
Well,
think
thanks for
so.
sharing. Yeah.